is Clinical Associate Professor. Dr. Rajesh is Clinical Associate Professor of Radiology, Neurosurgery, and Neurology at the University of Nevada School of Medicine. He's also Medical Director, Neurointerventional Service, Renowned Health. He's an interventional and diagnostic neuroradiologist at Reno Radiology Associates. To tell briefly about his experience, he's got more than 10 years experience in neurointervention and also has got a wide range of presentations in conferences and papers publications. So it's our privilege, and going a little bit into his teaching. He has got the Best Teacher Award while at Florida. He's also got the Best Teacher Award while at Texas. And his philanthropic activities, I have to tell that in 48 hours for our COVID-2 pandemic, he raised 1 crore rupees. I think that's a record. I think even any Indian here would not have done it with the huge population. So all this fundraising, he gave it to our institution, Coimbatore Medical College, and we were able to do so much during the COVID pandemic in April, May of this year. And he has also got a non-profit organization, the Ardor organization, through which he gives and donates a lot of medical material like catheters and all other hardware. So through that, he's also helping a lot of families. And so we are very happy to have you, Rajesh. And this is a very formal introduction, but I think we need a formal introduction because people should know about you and your work.
Thank you, sir.
Over to you, Rajesh.
So thank you very much. Yes, yeah, I have to tell Dr. Murali because I think 1 month ago only we just I just called, and it's a very I felt like being being friends forever. Like it's very warm, reception, and then you gave all the support, and it's like it's not easy. You go and there's already organization, you have residents, and then this is like thank you, sir. Thank you very much for giving me. I kind of feel like I'm part of the institute, radiology department, and even CMC. I know the surgery also. Dr. Venkat is here now, and he and CJ and Karupusamy and everyone helped me to feel like I'm part of it, which I've been missing. I'm almost all. Let me mute all.
Yes.
Okay, mute. Yeah, I feel like I'm back, and because whatever said and done, I feel like we have to do something for like a Coimbatore Medical College. It's something which gave everything for me. Like I just came after 12th grade, Sivananda, and then came to Tambu, Coimbatore Medical College. And I think Vasumati knows, I think 25 years ago, without knowing anything, just entering the med school. And that gave everything in the sense, like all the knowledge and everything. And then after that, we've been gone and doing well. I feel like everyone should think about that, like in their parent institute, and then, do, whatever they can, like it can be, anything like educational or monetary, anything to improve, to make the CMC to like a state-of-the-art institute. So, okay then, so let's start. Let me share a screen. So this is, so bear with me because I think I have some issues with the sharing. Cannot minimize. So they're telling I can't minimize while I am recording. So, Is it okay? Can you see the PowerPoint? Oh, I need to unmute.
Yeah, we are able to see. Rajesh, we're able to see.
You'll be able to see the PowerPoint. Okay.
Yeah, it's visible well.
Okay, good. Because sometimes it just my image comes in the middle. There's a dark box comes. That's what people say. Is there anything like that? But you can see, no problem, right? You can see everything clearly. Okay. So let's start with I think, what about now? Do you still see the screen okay? It's fine. Okay.
Yeah, it is okay, but your image is also visible, but the screen is also seen.
So the screen is small, right? Now the screen is small.
It's not small, it is filling, but along with your image in the corner, we are able to see.
Okay.
But it is visible. I think if you go to the next 2 slides, to see whether it is okay.
Okay. Okay. Okay, let's start. So, yeah, I don't have to tell the definition of stroke because it's just acute neurological dysfunction, caused by ischemia or hemorrhage, which goes more than 24 hours or until death. So that's an acute stroke. So today, so the reason we put the epidemiology here, I know there's a lot of numbers. People don't like the numbers, but the reason we know the numbers is it's very important to know the problem. Like this is a big problem. The stroke is a big issue. Like in the United States, around 800,000 people get stroke, and around 140,000 die. So that's a fifth leading cause of death. Of the stroke is a fifth leading cause. But there's an interesting fact here. The stroke was a third leading cause of death until 5 years ago. So what happened? And then that become fifth. That means it's like in a big change. That means we did something good because as a community we did something good. So what did we do? What changed is mainly people say is the endovascular intervention, because it's like we've been trying like a neurointerventional community and the whole is trying to do a treatment for the clot in the brain, but we couldn't because there's no devices. But in 2013 there was a new device came which changed everything. Now we are able to remove the blood clot 90% of the time. Like if the patient comes to the room, we can go and remove the clot. It's a very simple way. It's thanks to biomedical engineers. Because I always say, this is what I always say when I present. I'm like a pilot, like I can just fly, but the marvel is the flight itself. In the sense whoever made that thing, flying. It's a long history, right? Like Wright brothers started, years ago. So like that, this biomedical research people, they somehow found, they discovered or found a catheter which can go from a groin to the brain within a couple of minutes. So it just goes there, and with some techniques. I'm not telling it's so it just you need some kind of a technique and training and everything. A couple of years of interventional training, you can do that. But now we can do that. Remove the clot within 10 minutes. So that changed. So the stroke mortality to third to fifth. And globally also it's a big problem, like almost like 42 million is the prevalence, and 16 million people get stroke every year. And then globally is the second leading cause of death. So it's a difference. In the US, it's a 5th leading cause, and globally it's the 2nd. And I looked up it in India also the same way. It's the 2nd leading cause of death. So it's a huge problem. So that means, you know, we need to do something about it. So that's why this epidemiology is important. So Tamil Nadu, we kind of, you know, extrapolated, like, I don't know that's the right number, but I just calculated for a 7 million admit all the 7 million people, 7 crores people, so 70,000. Like, you know, it may be more than that, but that's the data. Okay, sorry, someone is keep coming, so I need to admit. So that's why it's just taking. So acute stroke, so it can be like a, you know, ischemic stroke or hemorrhagic stroke, because any neurological dysfunction, it can happen because of the block in the blood vessel, or it can be leak in the blood vessel, right? Like the ischemic stroke, it's 80% of the time, and hemorrhagic stroke, it's like around 20% of the time. So this is, I'm not going into detail because it's a huge topic, but here ischemic stroke, mainly the large vessel occlusion. Like, I will go into detail what is large vessel occlusion, which is, okay, anyone with a stroke, the large vessel occlusion is only 1/3 of the time. So the remaining patients may be a very, tiny small vessel occlusions, and it can be a venous thrombosis, can cause venous ischemic infarct too. So that's the ischemic side of it. So here in the hemorrhagic side, ICH, like a parenchymal hemorrhage due to the hypertension, that's one common one. Subarachnoid hemorrhage, mostly aneurysm, and subdural hemorrhage, epidural venous hemorrhagic infarct. Those are the hemorrhagic side. So mainly today we are going to concentrate ischemic stroke caused by large vessel occlusion. So we are pretty much dealing with the 20% of patients with acute stroke will have like a large vessel occlusion. So that's what we are going to discuss about it today. So what is large vessel occlusion? So that's, this is my drawing, and, so it's not that good, but I'm just explaining it. So this is a common carotid artery, divides into external carotid and then internal carotid. And then it goes, divides middle cerebral, anterior cerebral, and then this is M1 segment. So we need to know what is M1, M2, M3, all those things, because that's what we talk in the radiology report, we put it in. So when it bifurcates ICA, then the first segment is M1, then again it bifurcates, this is M2, again it bifurcates, that's M3. So this is again A1, A2, it goes on like that. So any blockages happens ICA, M1, A1, and M2. So that areas, this is anterior circulation. So that's the large vessel occlusion in the anterior circulation. So in the posterior circulation, this is vertebral artery, intracranial segment, and then the basilar, and then the P1 segment. So the P1 segment divides, and then it divides into P2 and P3 and so on, but we don't do anything with that. But I do sometimes P2 segment, that depends on the clinical scenario. So that's the large vessel occlusion. So when you do a CT angiogram, when you see the blockages here, and when you call, and that's what we mean, like what is large vessel occlusion. So large vessel occlusion itself, 1/3 in the sense, this is what the stat says, like 240,000 people and 21,000 people in a year in Tamil Nadu. So the management of a stroke, it's a huge topic. Again, pre-hospital management and systems of care, where like, EMS, the emergency medical service, first responder, they need to stabilize the patient, and they need to go, they need to, go to the proper hospital. That's very, very important, because when the patient has a stroke, when they go to the hospital which doesn't have any stroke treatment option, then we are wasting time. So it's a very important, as a community wise, we need to set up systems of care, which, okay, what happens, like if there's a stroke, if the EMS goes, or emergency medical or ambulance, they need to know where to take the patient to the, which hospital to go. So that's very important. And then ED department, in the emergency emergency department, you need to make sure you do this, order the CT, CTA and all the studies quick enough so you don't waste time. And then you give the treatment right then and there. And then you specific treatment for the stroke, and then treatment of complication, and you send the patient home with the rehabilitation, and then the secondary stroke prevention, because we don't want another stroke to happen. So it's a lot of things, but today I'm going to concentrate on two things. One is like imaging of stroke and endovascular intervention. So only two very small topic, like imaging of a stroke and then endovascular intervention. So it's again, like I'm not entirely covering the whole stroke thing. Okay, so this is important slide, like why what is the mechanism of large vessel occlusion? So why this? Because as a resident, this is for the residents. Anything you read, anything in a practice, if you go into a little bit basic and learn from the very basic, and it is easy to remember and it's easy to apply practically. So whatever whatever someone is telling, okay, hemorrhage is bright on CT, and then we should know why the hemorrhage is bright on CT. So why is hemorrhage bright on CT? So what is hemorrhage? The hemorrhage is hemoglobin, right? Like the blood. Then if you go into detail, the hemoglobin is made up of heme and globin. And what is heme? Heme is a ferritin. So the ferritin is ferrous iron. So what happens to the ferrous iron? So then X-ray comes, then the ions kind of blocks the X-ray. It doesn't let that thing goes, or so that's why it's like then we can the image is bright. The same thing true for a calcium. That's why the bone is bright. So once you know why and what, and then same thing in MRI, the hemorrhage is dark on MRI. So why hemorrhage is dark, or sometimes bright on T1 weighted sequences because of the methemoglobin. The methemoglobin, again, the same thing. The ferritin, it's a paramagnetic effect. So once you know the mechanism, then it is easy to apply and remember it. So that's just a tip. So again, so I like this mechanism and physiology and pathophysiology. So I'm just going into a little more detail. So here, the common one is from the heart. So what happens, like mostly here in the US, I'm not sure in the Indian population, atrial fibrillation is very common. And when it is, the atrial fibrillation, the left atrium is not contracting properly. So because of that, the thrombus accumulates, and then that will come to the left ventricle, and then aorta, then into the intracranial circulation. Most of the time it goes somewhere else, but unluckily it can go here and land in the some of the vessel. So that is the most common. So the beauty of that is there's nothing, that the pathology is not in the brain. The blood vessels are very nice. They're like, it's completely fine looking blood vessels. But unfortunately, the clot from somewhere comes and blocks it. So because of that physiology, if we remove the clot, it become normal again. It's not like a cardiac system, like in a myocardial infarction. The pathology itself is this one, like the atherosclerosis itself happens in that particular vessel. And then the atherosclerotic plaque ruptures and clot forms there. And that is also large vessel occlusion. That also happens in the brain also. The atherosclerosis happens in the artery, and the plaque ruptures, and then platelet accumulates, and then it creates a large vessel syndrome. But that's rare. It's not that common. So this is the most common mechanism, is heart to artery. So the other common mechanism is here, like artery to artery. So the internal carotid artery bifurcation, which is the plaque forms right there. And then this plaque ruptures, and then clot accumulates. And then because of the blood flow, this clot moves there. So that's another very common mechanism. So the three mechanisms are heart to artery, artery to artery, then this is artery itself. And then the other, there's a cryptogenic causes. Sometimes we don't even know. Patient presents with the large vessel occlusion, we don't know where it's coming from. So sometimes we look at the heart with a patent foramina fovel. That's what we're thinking. Maybe the DVT, and it comes all the way to the heart and lung, and it goes into all those theories are there. And now with the COVID, we're seeing a lot of patients with the stroke, young patients, maybe hypercoagulable status or clots forming somewhere, we don't know. So it's a cryptogenic cause of vessel occlusion is also there. So that's the mechanism of large vessel occlusion. So again, this is very informal. If anyone wants to raise it, raise hand or something, you can see, then I can stop and answer the question. So that may be the easiest way, for the interaction. So is it clear until now? Okay. So this is a very, very important slide. It's my favorite slide when I present a stroke. So what happens? So this is the blood vessels and this is the clot. So as soon as the clot, go and obstruct the flow, so the cerebral blood flow decreases. So normally cerebral blood flow in a number wise, it's a 50 ml per second, or 100 grams, I think. So it's just blood is going, every minute. So if there is a block happens, and sometimes this collaterals, like leptomeningeal collaterals, it's a well-formed collaterals, it will take over the blocked ischemic territory and then try to supply it. Like that's very, very important. If you don't have any collateral, imagine if just the clot goes and then there is no flow, absolutely a zero, right? A zero blood flow is going, then immediately the brain dies. It not even more than a minute or so. It's a global anoxic injury. There's nothing coming out of it. Then even if you do anything with that, nothing happens. So that's why, when the intracranial bleed or a trauma, anything with epidural hemorrhage, patients get ICP, intracranial pressure, global anoxic injury happens. The blood doesn't go for a few minutes. The patient dies because this brain death happens. Because brain cannot tolerate, ischemic, zero. If it has some blood has to go. So here, what's happening because of the collaterals, something is going. But this is the interesting fact: the blood flow, if it's up to, if it's imagine there's like at least like some blood flow is going, more than 20%, 30% blood is going there. So the neuronal activity stops. It stops firing. So that's why you get a stroke symptom, but the cells are still alive. So that's the mechanism. So that's why you get a stroke symptom, and but still the brain is alive because there is some blood flows going. So you need at least 30% of blood flow going to make the brain, keep the brain alive. So that's why this penumbra is important. So if it's less than 30%, that means the brain will die. That's a theory. We don't know this number, 30%, whatever numbers they're coming up with. It is a theory. We don't know exactly what number it is, but at least for our point of view, or CT, I'm going into the detail about the imaging the the ischemia. So for that point of view, let us keep a 30%. So anything less than 30%, we have to assume the brain is going, dead brain. Anything more than 30%, we have to assume that is the ischemic brain. So any questions in this slide? because I feel that's an important concept to understand. So again, this is just my drawing. So I just to keep. So here, there's three scenarios, right? Three scenarios. So this blood is a block here. This is an unfortunate patient with a complete block, like the whole thing is blocked there, and is dead. No collaterals. If you look at the imaging, the cerebral blood flow is less than 10, and there's no salvageable brain. So there is nothing else to do. Unfortunately, we can't do anything. So here, this patient, if there is a block, there's an ischemic core, a small core, a big ischemic area. So this is the patient we can do and we can treat. Because if you remove it, this will have an infarct and this person will come back. So that's an ideal patient. So what about this? This is a clot, and there's a lot of collaterals, right? So there may be some patients we don't know with a stroke, they're not even coming to the hospital because it's a good collaterals. So that's why we see, later on there, ICA occlusion. That's a very perfect example. We see like 80-year-old with ICA occlusion, no symptom whatsoever, and they're like perfectly fine because of good collaterals. So what happened if there is a clot you see with a very mild TIA symptoms? What to do with that? Do we need to do anything? Before, like maybe 5 years ago, we've been thinking, well, let's not do it, because why to do and cause all those, whatever we do, that's a complication, right? Like we go and try to remove, I may create complication. But now the research is saying, if they did a study, so what they found is, even with a minimal TIA, with a large vessel occlusion, the chances of a second stroke is very, very high. It may be due to, there's a pressure dependent situation, and, if the blood pressure goes down, they're getting symptom, or the clot is breaking. And hello? Okay, so someone talking. So, or the clot, let me mute. I don't know. Can everyone mute? It's someone talking. Okay, yeah. So that collaterals. The clot can break and cause like the TIA symptoms. So that's why now they're telling, if you find a large vessel, even with the minimal stroke symptoms, it's better to remove it. So that's the pathophysiology of large vessel occlusion stroke. So this is a natural, again, this is the very important thing, natural history of a disease. So I know there's a neurosurgery, neurology residents and radiology residents here. Like I'm like, whenever you read, whenever you try to treat a disease, it's very important to understand a natural history. So when you go and talk to the patient, right, when you go consenting or relatives, so we need to tell what will happen if you don't do anything. That's very, very, so, because the treatment comes only now. So what happens in large vessel occlusion if we don't do anything? Why we need to do it? Because that's very, very important, because that's a strong point to convince a patient, and even the, if the new procedure is coming to the institute, we need to convince our administration to bring the new devices and everything, right? So for that, you need a natural history. So this is a busy slide. So let's concentrate on this one. This just this one, which is 6-month mortality rate of a large vessel occlusion is 26% versus 1.3% in a non-large vessel occlusion. So what it says, like if the patient comes with a stroke, if you find large vessel occlusion, and 1/4 of them are not going to be alive. So that is in 6 months. That's a huge number. So if you look at it, 70,000 people in a stroke in a year. So like a 1/3 is a 20,000 people in Tamil Nadu is dying with a large vessel occlusion every year. So that's a number. If you look at it in a Coimbatore, you can just say maybe 5,000 people are dying in a year, something like that. So that's a huge number. The reason is, I know everyone, this death is inevitable. Everyone is going to die. But as a medical community, if we know which is a preventable, or maybe you can avoid, and we do have a treatment, and we can do like at least 60% of those deaths can be preventable by doing this treatment. So that is the very strong message we take and we implement in our institutions. So that, in that sense, I feel like the natural history is very, very important. Okay, so let's talk about what do we do intervention to alter it. So we want to alter the natural history, right? That's our aim as a medical community. So you can do a medical management like IV thrombolysis. It's very important. This is a very important question. People ask me, oh, we are giving a thrombolysis, there's a large vessel occlusion. Can we just take the patient to the thrombectomy? The answer right now is no, because there's a treatment. There are a lot of the research coming. There's some saying, you can bypass, some saying you cannot bypass. So the current guideline is IV thrombolysis is the treatment of choice, in the sense you give IV thrombolysis while taking the patient to the thrombectomy. So still you need to give IV thrombolysis. So you give IV thrombolysis. It works. If it is a large vessel occlusion, then it works only 10 to 30% of the time. So it works better on a small vessel strokes, like a tiny strokes. It works because it's a clot burden, but it works only 10 to 30% of the time if it is a large vessel occlusion. So that you do here in our institute, it's a very important, like a door to needle time. We want to keep it within 30 minutes. If the patient comes to the ER within 30 minutes, if it's eligible, the patient is getting a TPA. So then the endovascular management there's a lot of, there are a couple of things we can do. One is we can go and remove the clot. It's a simple plumbing thing, like, just put the catheter, aspirate, and then there is a technique, a stent retrieval. Now you put a stent which is attached to the coil, then you can remove it. So that's the common thing we do. Then other things we do, like when it's sometimes what I do is when it is carotid occlusion and that clot moved into the brain, so there's no way to go there. So you need to do something in a carotid. You put a stent, and then you go and remove the clot. So that's possible. So sometimes, like I mentioned, the mechanism, it may be an intracranial atherosclerosis itself causing it, right? So then for that, you can go and do angioplasty or stenting in intracranial vessels, and then you do the thrombectomy. So all those things we can do to make the blood flow into the brain. So those are the things. Today I'm going to cover, these parts. Okay, so this is the very important slide. This is the take-home point I want to people, residents to take, the message. So you find the large vessel occlusion, right? So there are three things we want to make sure. The three things, like if there is a stroke patient, the 4 points. The first is, is it a large vessel occlusion or not? Right? That is, so it's like a ECG. That's what I tell. Like there's a lot of resistance in my hospital 10 years ago when I started this program. In Reno, there was not a stroke. And like I came here and then I started, that time we're doing 1 or 2 strokes in a year. Today, in 10 months, 9 months, we did almost like 110 strokes. So we're doing around 160. So in the last 10 years, there's a lot of things I need to do to make this thing to happen in the Reno area. So there's a lot of resistance, but now there's a data supporting, but so everyone knows about it now, and then there won't be that much resistance to the CT angiogram. So the CT angiogram is like a ECG for us. If the patient comes with a heart pain, like chest pain, we do ECG. Why? We need to find out is there is STEMI or not, right? The ST segment elevation or not. So then the treatment differs. The same thing, the CTA will find a large vessel occlusion or not. And if it's a large vessel occlusion, then we need to do something. So means you need to remove. So for that, we want to make sure there is no hemorrhage. Imagine already there's a bleeding there and you go and remove the clot, then you're making the things worse. So we don't want the bleeding. And there is no, so we don't want already completed, already the brain is already infarcted. That means the patient may be coming late, or the patient doesn't have any collaterals. So this unfortunate patient, within a minute, it may be infarcted, or it went to some other hospitals, came back to our hospital. So we need to know how much brain is infarcted. So that is what is very important. And then we need to know this one, ischemic brain, that's a soft thing, because if there is already a high stroke score, small stroke volume, then we have to assume there's a big ischemia, right? Like the mismatch is even like a clinical, we can, and then a core infarct. If you see a normal looking brain, the patient is not moving, large vessel occlusion, we don't have to prove there is an ischemic brain. You can just, because this is clinically it's saying there is an ischemia. So it's mainly these three things we need to make sure: no hemorrhage, large vessel occlusion, no large infarcted brain. So this is another thing. The current guidelines are time-based, right? 4.5 hours you give TPA, and 6 hours you do this, 24 hours you do that. So this is all, it's all good, but why these numbers came is those numbers are taken from the trials, like a research. So the research, when they do research, when they take the patients in the research protocols, they need to come up with some numbers. So 3.5, 6, and 24 hours. So they have to prove if you do this, they have a benefit. So the guidelines follow that. But now, as a neurointerventional community, the TPA is very, still very time-based, because we want to make sure, right now, anyone with a 4.5 hours, we give TPA if it's eligible, and after 4.5 hours, we don't give TPA, right? That's a very hard, the time criteria there. But in a thrombectomy world, where the current guideline is you can do up to 24 hours, right? You can do up to 24 hours, but that is again an arbitrary number. Like what I do is, if the patient will have a no large infarcted brain, big stroke symptoms, and large vessel occlusion, we're doing it. Doesn't matter what time. Sometimes wake up stroke. Before 10 years ago, the patient would wake up with a stroke, right? Like that means just wake up with a stroke, don't know when the stroke happened. And then maybe we found the patient, unconscious, unknown onset. So what do we do? If we have this number, we don't know. So we used to say no. That unfortunate patient might have had a stroke a couple of minutes ago, and he can't tell when the stroke happened. And then we say, no, that's wrong. So that's why we are kind of moved away from the time, but it's not the guideline yet. It will come. So this is the guideline based on the randomized control studies, 0 to 4.5 hours, right? Significant stroke symptoms, no hemorrhage, no large infarcted brain. And if it's an LVO, and you give a thrombolysis and take the patient to mechanical thrombectomy. And then if it's 4.5 hours to 24 hours, it's all, if it's a no hemorrhage, all this criteria fits, you take the patient to mechanical thrombectomy. So it's pretty much simple. Up to 24 hours, you can, easily do it. Even after 24 hours or anything, if it fits into this criteria, you can still do it. So there's a lot of studies. It's proven that thrombectomy is useful. Like the same lectures I used to give 10 years ago, and people kind of didn't believe, skeptical. Even in my own institution, a neurologist 10 years ago, there was a thing, and then they said, Raj is doing this thing for money. This is what I got. Like, I don't get any, it's not too much money there, actually speaking. And I was like, oh my God, what are you telling? And they said, oh, you're doing because this is all fun for you, and doing because it's proven, there's nothing proven it. There's no use of it. That's what in the meeting. And then, there was a CEO there. And then I told, okay, then let's stop all the program. I don't want to do any aneurysm, any stenting, nothing in a neurointervention. I kind of let my credential go. We have a credentialing system. Like if I were to go to the neurointervention, I said, I'm not doing. Then the neurologist walked out, and then they said, okay, fine, you do whatever. And then in a couple of 2 years later, and the study proved that's why the study is so important. Is a belief is something, study is something, because you can believe, a lot of things we believe in it, even like Ayurvedic treatment, Indian, Siddha, Losan, we know it is working until we prove that into the randomized study. They're very difficult to convince people. So that's another take-home point for residents. Please, if you believe in it, try to do the research. Otherwise, it's not going to work. Okay, so let's talk in what is the goal? Like again, so we want to rule out hemorrhage, right? How do we rule out hemorrhage? Simplest way is non-contrast study, and you can do or you can do the MR also to rule out hemorrhage. That's the the first goal, ruling out the hemorrhage. And then the other one is like identify the large vessel occlusion in a stroke patient. Because in stroke patient, as I said, only 30% are a large vessel occlusion. So we need to, so for that, you can do the CT angiogram or you can do the MR angiogram. But CTA is a simple thing. Then you need to identify the salvageable brain or ischemic brain, and you need to identify the infarcted brain. So that you can do with a CT angiogram or a CT perfusion or MR perfusion. So here the CT perfusion is the, it's the CTA. You can identify the ischemic brain. There are some tricky points there, but the CT or MR perfusion is the one, it's useful to identify the ischemic brain. So then to rule out infarcted brain, like this is the main thing, right? I've been telling. So you don't want to do the stroke if it's already infarcted area. So the non-contrast CT helps, but CT scan maybe it'll give you the finding only after 6 to 8 hours. So what if the patient comes with a stroke within an hour, brain looks normal, but the brain may be already infarcted. You don't know. So then it's not that sensitive. So, but you can do CT angiogram, so you can get most of the finding. I'll go into the detail. And then the CT perfusion is, it'll give a lot of finding, but the MRI is the gold standard. That means if you do the diffuse and weighted sequences, then immediately you'll know the bright, and that shows ischemic infarcted brain, then you know for sure. But here we are running against the time, right? Like it's not like we have a lot of, in my institute, it's not possible to do the MRI that quickly. And I think a Stanford or a Mass General or a, good, there are a lot of hospitals, they can do this MRI immediately like a CT. Then you can take the patient to the MRI if needed. But I believe, it's my personal belief, I can get pretty much all the information for doing a CT angiogram. CT and CT angiogram, it's good enough for me to get every detail. And if I have a CTP, it's okay. But for me personally, I can get most of the 90% of the information by just doing a CT and CT angiogram. So which is what right now we got at CMC. So the point is, and then we have an MRI too, but we can pretty much can do a state-of-the-art treatments in whatever imaging we got at CMC. Okay, so let's go to this one, like hemorrhage, right? Like hemorrhage, I don't have to go in detail. Everyone knows that's hemorrhage is bright. So here you see the infarcted brain, and then that is the hemorrhage. And this is the gradient echo. Again, you guys all know, because of the ferritin, because of the heme, that creates the magnetic inhomogeneity. That's why you have the dark signal and the gradient echo, right? And then because of the ferritin, because of that metal blockage, it's almost like behaving like a bone, because its bone is what, like calcium, iodine is there, gadolinium. So same thing, the same concept here, it's bright. So this is the normal brain, I just put it in. Okay, so here, so that's the first goal, right? Like you do the CT scan to rule out the hemorrhage. And then what is the second goal? Like identify large vessel occlusion, right? This is the CT angiogram. You can see the blood vessels there, and then this middle cerebral artery is blocked right there. Shows large vessel occlusion. So here we have a software called Rapid AI, like a automated intelligent software. What it does is, once we do the CT scan, then it will go, the CT scan will, the technologist send the images to the virtual server, and then they automatically process it and send it to my mobile within a couple of minutes. So there is an alert even before it goes to the PAC station, even before any radiologist looking. So it's not that sensitive. It doesn't take our radiology role, but at least it alerts us. Okay, there is a large vessel occlusion, and then you look at it, analyze a lot of things. So it's not going to replace everything, but it's going to give us an alert. So then you go there and take a look at it. So you can do the MRI also. So that's the CT angiogram. So then to identify the ischemic brain, so you do a CTP, non-contrast, CTA. So here, this is what I want to spend some details, some more time. So what about the CT angiogram? How to identify the ischemic brain? That is, so where if there's a blockage, if you remember, like when I mentioned in the first slide, so it's a collaterals, right? Because of the collaterals, the brain is getting the perfusion. So you need to make sure you see the collaterals in that whole brain, the MCA territory. So that's the thing, that looking at the collaterals, it's very, very important. Then the other thing, you look at the CTA, the density. So it's basically you look at the density, where if the blood goes, the contrast goes. So that portion of the brain, the cortex, will showing the same kind of a perfusion like another side. Even though there is blocked vessel, because of the flow going from the collaterals, they have a good density. So because of good perfusion there. So by looking at those functions, so you can say the brain is ischemic, not infarcted. So when you do the non-contrast study, so normal cortical density and then aspect score. So the aspect score is something I'll go into the detail again. So where you look at the brain, so we divide the brain into middle cerebral distribution, the brain into 10 different segments for a communication point of view. So we divide into 10 different segments. We look at the cortical density of each segments, and if you have a normal cortical density or any dense area, normal dense area, then we give 1. That means if everything is normal, then we just gave 10, so which is a good score. And if everything is infarcted, that means hypodense, then you give the score 0. So for again, like I said, this is late, like this, you can't, this is like, it will take some time to the non-contrast study to give that the hypodensity. So when you just rely on this, you may miss the infarcted brain. But so that's why it's important, you need to have a non-contrast and the CTA also to analyze it. Then the CTP. So what is CTP? That's the next slide. So I'm going to, that's a CT perfusion image. So what happens is, so we give a contrast, right? Like in IB, and the contrast goes into the brain, and we just scan that small portion of the brain, like around, like in this region, like around this basal ganglia region, we just scan continuously. So what we'll get is, so we get the data. So we get the data when the contrast comes to the area and when it leaves and goes to the vein. So we get the real-time data. From the data, we kind of get some numbers. So 3 important things, at least find 2 important things we get it. Cerebral blood flow. So the numbers, the CT perfusion software will tell you, so the blood flow, if it's anything more than 30%, then it's not going to show any color. It's all, you can change into, you produce some color if it's 20, or it's all man-made thing. But here in this software, Rapid, so they say we kind of, remember I was telling, if it's anything less than 30%, if the brain is going to be infarcted, that's what we assume. So we assume here, so in this brain, the blood flow is going at least all the portion of this area, at least more than 30%. That's why there's no infarcted brain, right? And this is cerebral blood flow mapping. And then this is Tmax, that means like in the transient time. So here the contrast is taking more than 6 seconds to reach this portion of the brain, because when it goes, come back into the other area anterior, so it takes time, right? So that's why the delay, because this portion of the brain, the contrast is going, within 4 seconds. Like 4 seconds or less are normal. Like anything more than 4, anything more than 6, actually little bit significant, and that is selling. We are assuming that is ischemic area. So that is an ischemic area, and then there is no infarct. So you get this information. This is again very important, 2 things. If it's less than 30% cerebral blood flow, that is infarct. But if you look at the Tmax more than 6 seconds, that means it's delaying. If it's, that is the number, that's an ischemic brain area. So here, the CT angiogram, that's a CTP, but I understand we don't have a CTP yet in the Coimbatore Medical College. But to be honest with you, I don't rely on this at all, even though with these numbers and all. The reason is, it only gives a small portion, and then it's a lot of artifact. And then other important thing, if we go with the guideline, this is important, I want to make everyone make a, the first study proved, which is MR clean, and then they did not use the CT perfusion. So the guideline currently says, if anyone with a stroke onset less than 6 hours, you don't have to do the CTP at all. So the CTP, you don't rely on CTP, you don't do the CTP, because you don't need the CTP for anyone less than 6 hours. Even the guideline says. So the CTP, without CTP, we can manage it. But after 6 hours, the CTP is useful, but we'll go into the detail later. But Coimbatore Medical College point of view, we can get all the information doing this too, which is the CTA. So look at here. So that we can see the collaterals, these dots, and we can see the collaterals here, right? So very good collaterals. And then you can see the density, the cortical density is good. Then we can see the cortical density is good here. So this is the white matter, you can see the dot. So what does it indicate? This patient, just forget about this slide, and you can see normal collaterals, normal density, CTA showing blockage, and this patient is a very ideal patient. And then here, this is the non-contrast study. This is the aspect score, where there's a normal density here, normal density here, normal density here, normal density here. We already got 4, and then normal density here, normal density, and then this is like a 7 points. We get it, and then we'll one more slide, another 3 points. So the aspect score is 10. So when you read the CT and CTA, so you get aspects, and then you read a large vessel occlusion, and then you just score a collateral scoring. You can take any collateral scoring. Very simple scoring is no collaterals, intermediate collaterals, normal collateral. Like if it's a normal, like other side, good collaterals. No collateral means there's nothing blood vessels. And then you can see partially intermediate collateral. That's the simplest way for a communication. Okay, and then you can even do the CT angiogram aspects. So the aspect score is you divide the middle cerebral artery into 10 different segments, and looking at the hypodensity, you can do the same thing CTA for the better communication. So you can communicate clinics, whoever doing the procedure. So you tell, okay, there is a large vessel occlusion, aspect score is 10, good collaterals, and CTA aspect score is also 10, and it's a good candidate. So that's how you communicate. Okay, so this is again to identify the infarcted brain. Like how do you identify this? The same philosophy, like non-contrast study, and then CT perfusion, and then CT angiogram. So and then MRI, obviously. So but these two, here my point is by doing the non-contrast study and then CTA, you can get it. So let's go through it. So that's that. So let's concentrate on this portion. This is the CTA. So look at the difference. Even the CT angiogram, so you can see the normal perfusion here. So that's why it's normal looking cortex, good collaterals, but here it's very, very dense, right? Like a hypodense area. So that shows no collaterals, lot of cortical density. So this patient is already infarcted. So the same information, you get it here. This is the CT perfusion. What we do, cerebral blood flow, less than 30% the whole area. The blood flow is less. So that means it's already infarcted. So here the contrast is also going late. So that's why, so there's a matched defect. So Tmax, and this is matched. So this is the so we can't assume this is just an ischemic brain because the contrast is going slow, but this is already dead. It's so less is going. So that's what you get. Very, very, here it is like black and white kind of thing, right? Like you can convince, oh, it's mismatch and this and that. But here you need to look little. It is not all the time. This is not this clear. I need to admit. Sometimes the CTA is not good, but you can get some information. And then this patient, even aspect score is low. The whole area is infarcted. So in this juncture, I want to tell you, this is an MRI. Obviously, it's a huge infarct. So I want to tell you one important thing, because this is, again, I'm not telling, this is research, some research proved. Dr. Mayan Goyal mentioned it in the conference. Imagine a city A and then city B, right? City A has got 100 strokes, City B is also getting 100 large vessel occlusion in a year. So the City A, they do all kind of imaging thing and this and that, very strict, and they do a stroke only few patients. Like they select very carefully. So they do only 10, just imagine. And they get a very good results because they make sure the good candidate and good hours and this and that. So they'll do only, they know for sure they're going to benefit the patient. So they remove the clot. So out of 10, 9 patients will get benefit, right? So the 90 patients, they didn't even do it. So what will happen, 90 patients, 30 of them will die, and a lot of people will have a big stroke syndrome, right? So come back to the other city, the City B, the neighboring city, and this neurointerventionalists, they do, stroke for almost like a 70 patients, like because they don't want to, they have a very loose criteria. So if you look at it, they, even though they may help only 60% of the patient, but they may end up helping a 40 patients making better. And then out of whatever they do, sometimes even you do a futile intervention. Dr. Mayank Goyal says, if you do the treatment for an already infarcted brain, I'm not telling you do it, but if somehow you don't know it's infarcted, you did it, you are not harming. Because what is the issue means? You do it, if it's very rarely it bleeds, actually speaking, nowadays we are learning, if you make sure the blood pressure control, but even if it's a futile intervention, who cares? Like if you don't do it, the patient is going to get infarct. If you do it, the patient is infarcted because you are not helping. And even if it's bleed, the patient is going to die. With a big infarct, there is a 100% people will die because of the malignant hyperperfusion syndrome. So there is no point of saying no to the lot of stroke patients. But having said that, I'm not telling you go and do the stroke in infarcted brain. I'm not telling that. But what I'm telling, you make a reasonable, thing to identify the large ischemic infarcted brain. Right now, even the study showing, there is a study called Hermes that they're telling, even the aspect score of more than 3, even if you see like a 2/3 of the ischemic area brain is infarcted, still those patients may benefit long term. So you have to be a very low threshold to say no to the, if it's a whole territory is infarcted, like a last patient's this patient I did not do it because there's no point. But if it's only this area, so only this area, only this, if it's more than one, that the current guideline is, aspect score 6 and above, you do it. But research is now coming out and saying anything more than like aspect score 3 or 4 and above, you can do it. But it's a discussion. It's not numbers. So that's why don't rely on numbers. It's a team. Your ED physician, the patient's family, and patient, if he's able to do it, and the neurology, neurosurgery, and radiology folks, like everyone discuss and make a decision. That's what we do. So that's why the team approach, it's not a one guy like doing this. So that's the renowned, like our renowned stroke protocol, which is CT, CTA, and CTP, and we do IV thrombolysis and we do thrombectomy. If it's, basically we do a thrombectomy up to 24 hours. I know we're running out of time a little bit. So since it is informal, everyone at home, so please feel free to go out. So I don't mind. And if this is going to be recorded, and if there is something, then we can post to the YouTube or global alumni website for later on. So don't worry about it if you have any family obligations, dinner time and all those things. I don't mind. I can keep talking in front of this without any audience. So that's okay too. So that's the, endovascular intervention, like what we do, all those things. I think we covered everything. If it's a large vessel occlusion, we do aspiration thrombectomy or stent retrieval. I'll put some videos. And if it's a carotid stenosis with large vessel occlusion, we do carotid angioplasty and stent, then mechanical thrombectomy. If it's occluded carotid, I do like go and open the occluded carotid and then go and do the mechanical thrombectomy. Because basically, you need to have a large vessel occlusion to do all those things in the acute setting. And then even if it's intracranial atherosclerotic stenosis, so I go and remove the clot and open the vessel and all those things. So we can, 90% of the time, thanks to engineers and companies who were making these devices available for us, so we can able to do this, open it 90% of the time. So that's a very, very huge thing, in the interventional world. So so just a picture. Are you seeing it? Are you guys seeing? I think maybe you're seeing the video? Seeing the video? Okay.
Yeah.
We are able to see the video.
Yeah, we are able to see your yet to on, I suppose.
Is the video playing? Seeing, because I think the video is playing to the different screen.
No.
You're not seeing, right? Yeah.
It's not playing.
Yes, I know why it is, because it is playing into the different screen. I don't know how to bring it, but again, that's okay. I like this thing because it's like a video, but in a YouTube, if you go and put it in, it's a lot of things come. So it's this, like here, like let's go through this just a little bit. So if it's a clot, we go and put the catheter here, and then we just suck it. We just suck. And this one is just, we'll go and put the catheter, and then we put a stent, and then we remove the whole stent. That's okay. Let's leave this video alone. What to do, but let's go to the other. So let's go to some cases, right? I think Dr. Muralitha asked me, to go these cases first, but somehow I kind of forgot. I have everything, but that's what the case. I'm going through the 4 or 5 cases, interesting cases happened in last 3 months. So this is 66-year-old male, right side weakness, aphasia, and right gaze preference. Last known well is 4:30 p.m. evening. The NI stroke scale is 18. So very high, like a very high stroke scale. So this patient comes in to the hospital. So somehow the patient reached 4:30. Even here, like look at that, the timings. It's like 9 o'clock. We're doing the CT scan, which is sometimes here they go different hospital. I don't know what they think. So there's community education is important. So when we do a CT, so what is the goal? We want to rule out, CT, non-contrast CT, there's no hemorrhage. So look at the aspect score is 10. That means this is normal density here, normal density here. Now you compare with the other side. So normal density here, normal density, in this internal capsule, normal density in the insular region. See this, you have to look carefully at, this cortex. So it's like a little bit bright compared with the white matter. And then normal cortical density here, normal, and then normal here, normal. So here the aspect score is 10, no hemorrhage. So that means the patient can get the TPA, right? So they got the TPA immediately. The pharmacy had been called, we got TPA. So now, then what is the next goal? Basically to find out large vessel. So we don't waste time. Every stroke patient, we do the CT, CTA, and CTP, whatever, immediately. We don't do a CTA and we don't do all those things. We just at the same time. So just do everything at the one time. So then the large, you will find the MCA is occluded. So then you tell that this is for residents, radiology residents. So aspect score is 10, no hemorrhage, LVO, then what else to look for? Immediately you're thinking, okay, so let us look at the collaterals, right? So look, there is a nice looking collaterals. You can see the collaterals here in the Sylvian fissure. 1, 2, you can even count. There is a counting thing there, like a 1, 2, 3, 4, 5 blood vessels there. But here also 1, 2, 3. So this is a good collaterals, right? And then this density. So for the density, you need to alter the window level into window width into 40, 40. It's a good, then you can make it a little bit visible. So here is not a good, it's a little bit of vascular density, vascular CTA thing. You can change into the brain. So you can see, make sure the CTA aspect score, also good. So that's the way to communicate our clinicians, people who are doing, because since we don't have a CTP, so make sure you spend time to understand the collaterals and then density. So in that way, we can get most out of it. Then it's basically a neurointerventionalist, neurosurgery, neurologist, everyone looking at it, make the, the decision. It's a combined team decision. So here, so we do the CT perfusion. So look at the CT cerebral blood flow, less than 30% is 0 ml, right? So there's no infarcted brain at all. And then this is, the contrast is going very slowly. So that means its Tmax is more than 6. So that's a big ischemic area. So there's a big mismatch. So look at this, the rapid, they even, it wakes me at 9 o'clock. I think I remember I'm at home, playing with my kids, and then I get this alert in a with the software. We'll just, let me show you. So it just in the mobile, it will come like this, like alerts. Oh, this is the, let me do. So here, this is what it comes. It's not that clear, it's blurred because of the background blur. So it will come as an alert, and then I call the team. So I'll tell the team, okay, come on over, we're doing the thrombectomy. The patient is getting TPA already. So that's the angiogram. So 10:15. So within an hour. So we are trying, it's just like a 60 minutes. The patient in the angio room, even like 45 minutes, I go and stick the groin, femoral access, and by doing the first angiogram, it's 10:15. So you can see it's cut off. The middle cerebral artery, it's not flowing, but this is collaterals here. So that also, it's very comforting for me to even to look at the angiogram. So you can do the angiogram. There is a study now, Dr. Chitra from Stanford just told me, you can do a CT and directly take the patient to the angiogram and do this collateral assessment and everything, if you predict the large vessel occlusion clinically. But I think the CTA will helpful for a different reason. So, but you can get the collateral flow here. So within like a 10 minutes, so we go and put the catheter and aspirate, and then that's the whole thing is perfusing. So then what to do? So it's not over. Then the patient get admitted into the ICU with the blood pressure, with less than 140. So we do the scoring system, like a Tiki scoring system, which is, if it's everything is open, that is Tiki 3. If it's very little clot somewhere into the distal segments, that's Tiki 2B, which is the ideal. 2B and 3 is, but that's what we are looking. So if there is a good perfusion, we want to reduce the blood pressure. It's a very, very important, because you don't want, the blood pressure is, 180, 200 with hyperperfusion, then you're increasing the chances of bleeding. So that's, then afterwards, you do MRI, so very tiny strokes. So imagine the whole ischemic brain, like what we said, this person would have been infarcted because these collaterals may not stay more than 24 hours. The brain will not survive with this kind of a collaterals more than like a, we don't know the arbitrary number, but I don't know, long, it will not survive, so the time is very important. So it depends on patient to patient. So here it's a good outcome because the patient left with the NH score of 2. So we can do this kind of work, but not all the time. Again, so we can even, I'm just showing the case which I did. I have a lot of patients which I do, it become a futile, there's a complications and everything can happen. But the thing is 60% of the time. So if I do 10 patients, right, six of them are going home with a good outcome. With 6 of them, the MRS stroke scale, like a modified Rankin scale, is 2 or less. That means they're independent. So that means they're doing good. So there's another number. There's something called number to treat, NTT. So what is number to treat? The number to treat is whenever you do the surgery, you need to know how many surgeries you want to do to make the one patient better. So here in the thrombectomy world, you have to do 2 patients to make one patient better. So which is very, very low number. This is a good number. For example, for a cardiac intervention or a thrombectomy, it is more than 10 or something, 12 or something. You need to do 12 to make one patient better in a long term. So for a thrombectomy, you have to just do the 2. So it's a, when we start doing it, you are going to see, out of, if you do 3, 1 will get no better outcome. They may not improve at all. We cannot, but the 2 patients, we did some magic, the patient going home, living life happily. So that is what the important thing here. So again, this is one case, but I'm going to show this a lot of cases. There are 3 or 4 cases I'm going to show and the detailed thing. So I know it is a time already, 1 hour is passed, but I'm going to continue. Again, it's going to be recorded. So if someone, it's a time is, want to go, please take your time and leave the meeting, but we can upload it later on in the YouTube. So you still get it. So this is another patient, 66-year-old with a left-sided aphasia and last known well is a 9 a.m., right? 9 o'clock in the morning, and NH stroke scale is 21. So again, the same thing, like again and again, like here, look, there's no hemorrhage. Aspect score is 9. So why is 9? Anyone picked anything? See, there is a small area of cortical density is missing here, right? There's some areas missing, but everything else is okay. Like here, the insular cortex is missing here, but it's like a 3 here, 4, 5, 6, 7, 8. So it's like a 9. There's no large completed small infarct here. They're getting a TPA. I'm not sure this patient got a TPA or not. Then we did the CTA. What did we find? We find the internal carotid artery is severely stenosed or almost occluded. Very little blood is going. And then it was a big block, occluded the ICA bifurcation too. So it is a big, so the mortality rate in this patient is very high because but there is a good collateral. So you can see the good collaterals there, right? So no perfusion, there's no, here the blood is going through the anterior circulation, through, it's supplying it. That's why the blood flow, cerebral blood flow is still more than 30% of normal. That's why it's not infarcted. And then there's a large area of the brain showing Tmax, that is like a transient time is more than 6 seconds. That is ischemic brain. So if that's what's the mismatch and everything. So this patient, that's a cerebral blood flow. And then this rapid is sending me. But I know we do not need this. We don't need this at all. All information we can get from here. So you have good collaterals, good density, large vessel occlusion, good aspect score. It's good enough. You don't need this thing. So this, okay. So here is my angio at 3 o'clock. So why 3 o'clock? So because the patient came late, at 2 o'clock is we did the CTA, and then around like within 40 minutes, the patient is in the room, and that's my catheter in the internal carotid, common carotid. So you can see the whole thing is occluded. There is no flow, right? So this after the stent. So immediately what I did, I go and park the embolic production device, did the angioplasty, then put a stent there. Here there is a stent, and then this is now open. And then there is a block here, right? So you look at this. So this is after the stent is flowing, and that is blocked. And there is some collaterals there. And that is 3:31. And then I put the catheter and suck the clot out. So then that is 3:58, this complete flow. So this is the next day. So this is actually an interesting thing happened. This is my birthday. May 31st was the birthday. I did like 3 cases that my birthday, and 2 went very well. The other one, I couldn't help with a big infarct. So, we can't, we are not God. We can't go against statistics. It's because of a lot of factors. It's not because of the procedure. It's because, fetal intervention. So, but I was happy with this patient. The patient is awake, alert, and everything is good, going home. It's a little bit, moderate neglect on the left side, a little bit of stroke, but MRS stroke scale is less than 2, functioning, living life and enjoying it. So that is the another thing, right? Like what I said, first case I showed, simple one, MCA. The second one is, this is a little more intense. Even our own community, even US, not everyone will go behind it. They say if it's carotid occlusion, it's not a candidate. That's what they say. Even here, some neurointerventionalist, I don't, again, it's not the guideline, not, if you don't do it, they don't come behind you in the sense, okay, because it's too aggressive, because the guideline says the class 1 evidence is only for a M1 clot. But if it's occluded carotid, it is depends on the people to go how aggressive you want. Okay, so this is another patient, 77-year-old with a left facial droop, left upper extremity weakness, last known well is 6:30. So here, aspect score is 10. So look at, we don't even know which side is abnormal, right? Nice cortex. And then if we do CTA, you can see there's a block here. So the same deal. So what do you do? It is this, good collaterals, good, because this is the vascular density parameter. That's why I'm not, everything looks dark. But if you alter it, if you make it as a brain window, you will see the nice density like this, and nice perfusion and nice collaterals. So then you know what you're doing. But this is just a, okay, so this is good. So look at, so what you can see the collateral, you need to look carefully a little bit. So you see the collaterals here, you see the collaterals here, and the density is good. So aspects is good, and the CTA, this is an outside facility, I think, someone else, I think this is done on a 16 slice. So then, we saw, okay, it's a good candidate. We took it for, because that patient, see, this patient, I didn't even do the CTP because outside facility, they don't have a CTP. So they're transferring the patient here, and then I don't need it. This is a perfect example and you don't need it. This is the 16 slice CT scan. You you make the decision based on these images. This patient comes here, do angiogram, found out an interesting thing, and I did the thrombectomy. It's still like very severe stenosis here. So this patient is an intracranial stenosis in a M1 segment. Like it's an atherosclerotic disease here. So I heard there was a paper. I don't know personally. I didn't confirm it. I mean, the Asian population, Southeast Asian. I don't know about the India. What is the data? But there's more patients with intracranial atherosclerotic disease. So you may see the more of intracranial atherosclerotic disease, but I'm not sure. I'm just this is just a paper, one paper. So that's angioplasty. Let's do the after the angioplasty. You know, this is the balloon I put. You know, if I put a balloon, there is no flow, and then this is after angioplasty here. There's a good flow there. So if you don't do the angioplasty, even if you do the thrombectomy, and then you leave that atherosclerotic plaque untreated, it's going to close right away. I've burned multiple times. You know, if you don't fix it, if you don't put a stent, or if you do angioplasty and antiplatelets, it's going to close. So this patient did well with this. Again, it's doing good. Again, I'm showing all good cases, because I just don't want, you know, I have cases, but for a time point of view, I don't want to show the, you know, some patients after the stroke, after the thrombectomy, still have a big infarct or hemorrhage. But so that's one. So here, this is another interesting patient. I will finish this lecture with this, because the reason is not everything will go well, right? It can go in a different way also. To tell that 61-year-old, last known well 330, NH score is 19. This just happened like I think 10 days ago. I think 11th, I think. Here aspect score is 10. So look at that. No hemorrhage. And so it's all good. So, you know, you're taking the patient. So, and I did the CTA. So I see it, you know, good collaterals. So this is it's the ICA. It's a huge thing, because it's just completely blockage from here, it's all there. So, you know, but there's a good collaterals. You can see the collaterals and good density. See, look at the density. So this is what very important take home message. I mean, just look at this, like this, I need these three images, like blockage, collaterals, good aspect CTA, good density, and everything is good. So this patient, I'm taking the patient. But we do both CTP also, that confirms, right? Like here they say this is a little portion of the brain, like getting less than 30%. So this is infarcted area, but we can't, I don't know, maybe we can look at here, but it's difficult. So here you will find that this person is going to get infarcted, and the huge area of the brain, which is showing ischemic. So this is the rapid automated software. It comes to me, okay, this just like time wise, it's helpful. Okay, so that's 355. So I do an angio. Look at this, is no flow at all. It's a bad, no flow, nothing going, but ICA is okay. Then this is my first, I remove the clot, my first aspiration. So I could able to open the proximal M1 segment. So this is open. Just hold on a second. So this is the proximal M1 segment is open. So then M2 and M3 is still not showing the blood flow. So I need to go again. There's another aspiration. So look what happened. So I aspirated. Then what happened was the M1, M2, M3 all opened. So anyone can guess what happened here? Where is the A1 segment? So we were seeing A1 segment here, A2 segment here, but here we're not seeing it. So what happened was, when I removing the clot, some of the clot migrated into this A1 segment. So now what can I do? Like, I opened one vessel, this vessel is closed. But still better than, because I think the MCA territory is important than the, this one, but I don't want to leave. So I just did all kind of stuff, just a little more intense procedure to remove this one. So when I removed, I could able to open the A1, but the clot went in there, this A2. So it's not perfusing. So then after multiple attempts, this clot, I could able to bring it to the A1. The A2 was open. There is a patent anterior communicating artery. So I went and did the angiogram other side. So look at this. So I could see anterior communicating artery, this anterior cerebral artery. So it's flowing, and there is this clot sitting right here. And then this MCA is flowing. Then I thought, okay, let's not do anything right here because it's flowing here, it's flowing there, and this is just a small block here. And when I try to do every time, it goes here and there. Let's not do, because this patient the brain is perfusing very well everywhere. Tiki 3 score. So I just left this A1 clot alone. So then we did the CT. We did a small infarct. So look at that. This is what I want to just pay an attention here. So there, see the small infarct there? That is kind of almost same as this, right? The CT perfusion, we get that infarct, but we couldn't get that same information here. If you look at carefully, you would, but it's just useful to know, okay, this area is not going to be coming back. So that patient, he did very well. Mild right hemiparesis, mild dysarthria, went home. Disoriented, but he will do, 6 months, he will be back to normal or pretty much. So the reason I was putting this and is not all cases goes into, expected way. It may go inadvertent embolism can happen. Sometimes, bleeding can happen. That's the worst nightmare for me. Like you go, I've been doing 15 years, a stroke, maybe 3 patients bled during the procedure with the stroke. It can happen. So, and then you have a lot of bleed. So these things can happen. So, we can't do anything about it. So this is the Tiki score. The Tiki score, this is for the neurosurgical residents or the interventionalist who are doing, you need to follow this to communicate after the stroke, to communicate your neurology colleagues or ICU colleagues. Okay, what is Tiki score? 0 means no perfusion, 3 means completely perfused. Good. 2B is, that's what all the data trial, they're looking for 2B or 3. Because you may see a tiny clots in a M4, M3 segments. That's okay. Don't go behind, don't do anything because that is fine. So the 2B and 3 is the good outcome. 2A is you opened, but 50% of the flow is still not flowing. And 1 is, very, very little effect. So that's Tiki score for a communication wise. Why it's important? It's very important for a blood pressure parameter. So because if it's a Tiki 3, you keep blood pressure less than 140, systolic blood pressure. If it's Tiki 2B, you keep the systolic blood pressure less than 160. If it's Tiki 2A or 1 or 0, you can keep it up to 180. So because you still want the collaterals going, so you don't do anything. So that's why it's very important. Why to analyze and communicate. So every little thing you do, as a resident, like why we are doing this and why and what questions if you keep asking, that will make you understand the process much better. Okay, so that's this we covered already. You know, the futile intervention. I think I feel like you should err towards doing more than not doing at all, because you're not helping. And the number to treat we covered. And then whatever said and done, 60% people will have a better outcome. If you do 10, 6 will do better. 4 will not do, no change. Or at least you're not doing anything worse. But don't worry about if you do it, first case, okay, I didn't do it. Second case, don't worry. You know, it's a statistics. You do 100 patients, 60 will do better. And 5 will have a complication. This is, you can't go against the statistics. It will happen. But I hope will a community, and because if the patient comes to our hospital quick enough, these numbers will go. It's not like we are doing harm. It is because the patient comes to us a little later. We need a lot of changes. So even at Coimbatore Medical College, if you don't get the 60% in the first couple of years, even if you get 30% outcome, that's good enough. No, there's nothing to worry about because we are still helping. So other thing I want to make sure this, it's very important. Radiologically, it's very, very residence. So when you read the post CT, when you read the hemorrhage, this is an article there is a petechial hemorrhage. You know, you see a tiny little hemorrhage that's called hemorrhagic transformation. And then there is a huge hematoma that is called parenchymal hematoma. So you need to differentiate. Just don't call it as a hemorrhagic transformation. Then it'll give a bad vibe. Oh, Dr. So-and-so did it, the patient hemorrhage. No, it's like you have to put it in the report. It's a petechial hemorrhage. That means it doesn't have any consequence. It's okay to have a petechial hemorrhage. So that is a hemorrhagic transformation. 1 means like only small portion of the brain, less than 50%. In a hemorrhagic transformation 2 means more than 50% of the areas having a petechial hemorrhage. And then the parenchymal hematoma means there is a big, the blob of the thrombus there, you know, the clot, the hematoma, that is even less than 50% of the infarct. That is parenchymal hematoma. And then if it's a PH2, means it's a big hematoma covering more than 50% of the area. Just hold on just a second. Okay, so this hemorrhagic conversion is very, very important to, you know, to radiology residents to tell how to communicate. Even our own hospital, I'm struggling, but I'm sure we can be the state of the art. Like, I don't think any institute, even in the US, they're following this very, but when you guys do it, please, in a post thing, when you see the hemorrhage, make sure you follow this guideline. Okay, PH2, because PH2 is the only thing very significant. We consider that is a complication of the thrombectomy, because you did something, a futile procedure, and that bleed and big hemorrhage. That's the only thing we are worried of, not these 3. Okay. So complications we covered, you know, vessel perforation can happen, embolism to different vascular territory can happen, groin bleeding and groin hematoma can happen, you know, that you can't do anything about it. You know, means you can do something, but, you know, but sometimes it can happen. And then reperfusion injury, because hematoma, which is again parenchymal hematoma, not HT. I'm sorry, this is the wrong thing. PH2. PH2 is the only thing is the bad. But HT1, which is petechial hemorrhage 1, petechial hemorrhage 2, parenchymal hemorrhage 1, is not considered a complication. It is okay, because, or the other way to look around is, if you had a hemorrhage, the patient NIH stroke scale is more than 4 jumped, then you consider that as a hemorrhagic complication. You're almost done. So this also we covered. ICU, make sure blood pressure management, check for a groin hematoma, because you don't want to lose the patient with the bleeding in the groin, because the patient might have got TPA. Very carefully watching, make sure that femoral arteries are good, and you get the CT or MR within 24 hours. That's very important to look at what you're looking at, then you may have to do, if it's a brain swelling, you may have to call the neurosurgery, and neurosurgery colleagues can do the thrombectomy, so craniectomy and everything. So that is very, very important, immediate post-thrombectomy care. So this one, I'm not going into the detail, but because it's the numbers again, but it is there in a SNI in a website. I will put that thing later on. I will send it to you, this metrics. This metrics is very important when you analyze it. For example, you look at this metric 6. In 70% people, you should have a TICI 2B. So if you do 100 thrombectomy, 70 of them should have a TICI 2B. In our institution, we are having a 90. It's a guide. But even if you have, when you're starting the program, even if you have 70% people will have TICI 2B, you're doing good. If you're not doing 70% people, that means your techniques or something need to be improved. That's what it is. So it's the metrics. It's not about penalizing someone. Oh, you're not doing it. It is about self-improvement, right? Like you're improving yourself. So that means here, like, 75% people imaging to puncture time less than 1. If you do a CTA and you have a large vessel, within 2 hours, the patient has to be in the angio room. So that means if you're wasting another 3 hours to bring the patient from the radiology area to angio, that means you're not doing good. So all those things, all the metrics, someone has to, every stroke patient, and then every month we review, and then it is a process. This is work in process. It will improve for sure. Okay, so this is my best. This is my not best. This is my favorite slide. I will finish this. I'll be done. I'm sorry for the long, but so what we are doing.
Non-veg में एक टा dish बना लिया हो गया.
Okay.
दाल भात सब्जी में 3 टा dish बने वो करूँ तकरो बाद है कि पाउन करूँ क्या था कि
someone is talking.
चलो वैसे बढ़िया अपन चिकन मटन बना दिया.
Hello, can you someone is talking on the phone, can you mute? Okay. Okay, that's fine. So the prevention of stroke disability, so which is primary prevention, which is like, educating the community about exercise, healthy diet, no smoking. Those is very important, right? That's the big impact on the community. Then the secondary prevention, again, making sure you do routine blood test, you can do the carotid Doppler or smoking cessation programs for the community. Hypertension, very important. So all those screening methods, very, very important as a community to stop the stroke. But this is where we come, right? Like here, look at this. This is a huge, so if you look at it, it's too many steps here, too many steps here. There's only 3 things here. Even here, you can say, oh, this is easy, right? But this is tough. It's getting tougher and tougher. But tertiary prevention is tough. So what you need to do, symptom to revascularization as low as possible. So what, because every minute, 2 million neuron dies, right? 2 million neurons. So that means it's a very important community education. Even here, people, they just stroke, they just stay at their home, they come after 24 hours. So you need to educate the community how to bring. I know in our setup in our India and Tamil, there's a lot of different problems, a lot of different issues, but we can get through. We have to dream. We can get through all those things. And then the emergency medical service, ambulance, they have to be knowing to come to the Coimbatore Medical College or come to somewhere where there is thrombectomies available. We need to have that systems of care. In the sense, you need to tell the ambulance, everyone, don't go to smaller hospital, otherwise you are delaying. Even like in US, there is a legislation in Washington state, ambulance people cannot take the patient to the area where there is no stroke thrombectomy available, because the patient doesn't know, right? Like, so it's a huge thing we need to do. And ER, they need to drop everything, not like they need to triage the stroke patient. That is something, it's a personal, and a lot of issues may come in our ER because there may not be enough personnel there to take care of the stroke patient. So we need to work on those things also. So this thrombectomy ready centers department and diagnostic, that if you look at it, we have, I'm very proud to say our Coimbatore Medical College, we have a good diagnostic radiology department, radiology residents with the CT, CTA, and we are good here. And then same thing, neurointensive capability, we have like a biplane, we have like a neurosurgery, 3 neurosurgery colleagues are doing angiograms, and then there's now it's going to be a thrombectomy, we are going to do. So we have the capability, and we have a neurointensive, and I'm not sure dedicated stroke unit, but the rehab. So the tertiary prevention is this many steps, the different links there to make 1% better, but everything has a start. I think we can start, and 2 years from now, it'll be a different program. But again, I'll finish this. Again, thank you very much for this. I know it took almost 2 hours. It's a huge one, but I'm sorry about it. But hope I didn't spoil the dinner time, because here in the morning I'm just going to have a cup of coffee here and go back to my routine. And thanks a lot. Let me. Okay.
Dr. Rajesh, it was an excellent lecture. We really loved the free and almost casual approach that shows your command over the field, and that really take-home message about the stroke metrics, the TICI scoring and the BP management. Those were new things which I really learned today. And then the final thing is that we can err on the side of commission. That is the first, and that's the final thing that I want to reinforce what you have already told. We can err on the side of commission, do more, even though it may not benefit the patient. So that, as you said, it's better to do 6 results positive out of 10 rather than do 1 out of 2.
Yes. That's no doubt about it. Yeah. So now I can see there's a lot of people here, and so we can, like, sir, like you said, we can have like every 4th Saturday, right? Every 4th Saturday.
Yeah.
Then if for some reason, if I am not there, then we can change into 3rd or 4th. Depends on. I will let you know.
Definitely.
And we'll have a topic. I will send the topic and everything way ahead of the weeks, maybe 2 weeks before. And even I can send the slides also to people. So that way they have the slide, and then they can go through it. Then we can. Then again, I want to make this thing very thing like Tamil pesarudha enakku romba. Suddenly I changing into this, like the Tamil is every now. I'm very comfortable talking and communicating Tamil, and then I will send my email and phone numbers, and calling me about the CTA or anything. Now we can share Zoom sharing. Now we can do the CTE, and if you have any doubts on anything, I can be. Please consider me as your colleague, and we can. I'm really excited to be part of it.
You're also part of the team already.
Yes.
So it's
Okay.
nice.
Thank you very much.
This one. So we will keep in touch, and as we planned, probably once a month, 3rd or 4th, to your convenience. And if you feel Saturday is a little bit hectic, probably you can even schedule on the Sunday if that's fine for you. So any weekend, Saturday or Sunday, that's up to you based on your schedule.
That's it. Yeah. Thank you, sir.
Any
Thank you.
questions from any of the residents? One or two short questions.
Yes, yeah, questions. Yeah, please. Yeah, I didn't. Yeah, any questions if they want. I have all the time. You in the morning, so I can sit here another 2 hours, 3 hours also. So that's not a problem.
Just 1 or 2 short questions. Yeah. Any of the senior residents here? I think they're a little bit. Dr. Preeti, you ask 1 or 2 questions? I think Preeti wants to ask 1 question. Preeti is also an undergraduate alumni of Coimbatore Medical College.
Oh, great. Hi, Preeti. Do you have any questions, Preeti? Do you have any questions? No? Okay, you mute. Okay.
No, sir.
Okay, good. So if there's no questions, means only 2 things. Either I should have done very badly or maybe very good. It's a very
useful.
difficult. Yeah. So I learned violin. Now violin almost 15 varsama. 20 varsama. That's what like violin, like it's only 2 players. It's a bad, worst, or a great. There's no intermediate. So like that, if you don't have a questions, either I would have done an excellent thing or maybe very bad. So hope I did good. So people understood me, and any questions later on, the next lecture also you can ask. I'll upload this thing into the YouTube and everything. Okay. Vasumati,
Rajesh, thank you so much.
thank you. Just say Vasumati. I think she left.
Yeah, she's there. She's there.
Yeah. So so yeah, everyone wants to go and you can go, and I'm just fine. I'm just want to I'll just say something hi to Vasumati, and then we'll go from there.
Okay, Rajesh. Bye. Take care.
Okay, bye.